What if the thing that's been protecting you from falls, the daily exercise, the careful footwear, the slow and steady pace you've adopted in your own home, is actually masking a warning your body has been trying to send for months? And what if the stumble you dismissed last Tuesday, the one where you caught yourself on the counter and laughed it off, wasn't clumsiness at all, but the clearest signal your nervous system knows how to give? I know that sounds like an overreaction, but after more than 2 decades studying how the aging nervous system communicates with the body, I can tell you this with certainty. Stumbling is not a normal part of getting older, it is a message. And the older adults who ignore it, the ones who chalk it up to being tired or distracted or wearing the wrong shoes, are the ones who end up in the emergency room 6 months later wondering what happened. The confusion here is costing people their independence, not someday, now. Every year, 1 in 4 Americans over the age of 65 falls. That's CDC data. But the more important number, the one that almost nobody talks about, is how many of those falls were preceded by weeks or months of minor stumbles that were brushed aside. The stumble is the fall that hasn't happened yet. And once you understand what it's actually telling you, you gain the power to intervene before the fall ever occurs. In this video, I'm going to give you a complete framework for understanding what stumbling means. Not a vague talk to your doctor brush off, but a real specific map of the mechanisms behind balance loss in adults over 60 and what to actually do about each one. I'll show you a specific hidden calculation, something I call the triple system check, that you can run on yourself right now today, that will tell you far more about your fall risk than any single test a doctor typically runs in an office visit. Stay with me through the whole video, because the section at the end on what I call the silent tilt window is the piece that changes everything. It's a specific time of day and a specific physiological pattern when fall risk spikes in older adults, and almost no one is warned about it. That section alone could be the reason you're still living in your own home 3 years from now. My name is Dr. Kalb. I'm a physician with a focus on geriatric neurology and fall prevention in adults over 60. This channel exists for one reason: the conversation most older adults need to have about balance, stumbling, and fall risk almost never happens in a 12-minute office visit. This is still a young channel, and every subscriber genuinely matters for our ability to reach the people who need this information most. So I want to ask you to subscribe right now, not later, now. When you subscribe, you're not just saving the video. You're telling YouTube's algorithm that this content is worth showing to other adults over 60 who are navigating exactly what you're navigating. That's how this information spreads to the people who need it. Hit subscribe and then let's get into this. Most people who start stumbling more often want one answer: is this serious or isn't it? I understand that instinct completely. You want a number, a verdict, a clear line. But that question, serious or not, is dangerously incomplete because it assumes stumbling is a single thing with a single cause. It isn't. Consider this: the CDC reports that falls are the leading cause of both fatal and non fatal injuries in Americans over 65. That's not a statistic about unlucky moments. That's a structural failure happening across millions of older adults who received no meaningful guidance about what stumbling actually means or what drives it. The dangerous gap is this: some people are told to be more careful, given a cane, and sent home. Others, the ones who are actually at high risk, are reassured because they passed a basic office balance test. Both groups are getting incomplete information. So instead of asking, is this serious? I want you to ask three better questions. The first: which of my three balance systems is actually failing? Because balance is not one system, it's three. And each one fails differently at different ages, for different reasons, with different consequences. The second: is my stumbling getting faster, more frequent, or happening in new settings? The trajectory matters more than any single event. A stumble going downstairs is different from a stumble standing still. Each pattern points to a completely different answer. The third: what does my stumbling look like right before it happens? The type of stumble, catching your toe, veering sideways, freezing mid step, tells a skilled clinician more about the underlying cause than any single test. Once you understand this framework, stumbling stops being a source of fear and starts being a source of information. Before we get into this, where are you watching from today? Drop your city or country in the comments. I read every single one. Here's what's actually happening in the balance system of an adult over 60. And it's more specific than most people have ever been told. Your body maintains balance by continuously combining input from three separate systems: the vestibular system in your inner ear, the proprioceptive system in your muscles and joints, and your visual system. Think of it like a three legged stool. When all three legs are working, the stool stands solid. But as we age, each leg gets shorter. The stool doesn't fall, not immediately. It compensates, it wobbles, it catches. And then one day, on a slightly uneven piece of pavement or a rug that was always fine before, it tips. The medical term for the age related decline in proprioception, the system that tells your brain where your feet and joints are in space without you looking at them, is somatosensory attenuation. In plain language, the sensors in your legs become less precise. They fire more slowly. They send weaker signals. And your brain, which has been trusting those signals for 60 or 70 years, doesn't always know the signal is weaker. So it doesn't compensate. This is why many older adults stumble more in low light or darkness. The visual leg of the stool is gone, and the proprioceptive leg is no longer picking up the slack the way it used to. Two weakened systems without the third to compensate is the anatomy of a fall. A landmark study published in the Journal of Gerontology found that adults over 70 showed proprioceptive sensitivity roughly 40% lower than adults in their 30s and 40s. That's not a subtle decline, that's nearly half the sensory precision, happening invisibly over decades. Now, let me give you the specific numbers. For adults between 60 and 74, a gait speed below 1.0 meters per second, that's roughly how fast you walk across a room, is associated with significantly elevated fall risk. For adults 75 and older, the threshold drops to zero point 0.8 meters per second. In the watch closely zone, gait speed between zero point 0.8 and 1.0 for the 60 to 74 group, and between zero point 0.6 and zero point 0.8 for those 75 and older. These are early warning numbers. Below zero point 0.6 meters per second at any age over 60 is a serious signal that requires clinical attention. And here's the number most people never hear. The lesser known danger goes in the opposite direction. A gait that is too rigid, too deliberate, too slow and careful is its own risk factor. It signals a compensatory pattern, the nervous system slowing everything down because it no longer trusts its own signals. That hypercautious shuffle is not safety. It's the body telling you the system is under stress. I had a patient, I'll call her Dorothy, 72 years old, a retired librarian from Ohio. She came in not because she'd fallen, but because her daughter noticed she was walking funny. Dorothy herself said she felt fine. She'd started taking more time going upstairs. She held walls when she didn't used to. Her office balance test, the standard one, standing on one leg for 10 seconds, she passed. Her strength was fine. Her vision was fine. What wasn't fine was her proprioceptive response time. We tested it with a simple foam surface assessment, removing the floor feedback her legs had been compensating for. She swayed significantly. Her brain had been using visual input to compensate for weakened leg sensors for months, possibly longer. Put her in a dark hallway, a parking garage at dusk, a bathroom in the middle of the night, and the compensating system vanishes. We started a targeted vestibular and proprioceptive training program. Not generic exercise, specific, progressive, balance focused training. Within 8 weeks, her sway scores improved measurably. Within 3 months, her daughter stopped worrying about the stairs. Nobody had looked at her proprioceptive response. They'd seen a 72-year-old woman who was just being careful. If you're still with me and finding this useful, take a moment and type 2 in the comments. It lets me know you're watching. Now, I want to give you something you can use right now, today, with no equipment and no appointment. It's called the Timed Up and Go test, the TUG. Clinicians use it, but most patients are never told what their score means, and they're almost never told the threshold that predicts serious fall risk. Here's how to run it: sit in a standard chair with arms, have someone start a timer, or use your phone. Stand up, walk 10 feet in a straight line, turn around, walk back, and sit down. Stop the timer. A large meta analysis published in Physical Therapy, examining data from over 3,500 adults 60 and older, established these ranges. Under 10 seconds is normal fall risk. Between 10 and 12 seconds is a watch zone. Not alarming, but track it monthly. Between 12 and 20 seconds is an early warning signal that warrants clinical evaluation. Over 20 seconds in any adult over 60 is a serious signal requiring prompt attention. But here's the calculation that most people never run. Take your TUG score today and compare it to your TUG score 30 days from now. The rate of change is more predictive of fall risk than any single measurement. A TUG that rises from 11 to 14 seconds in 1 month tells you far more than a score of 14 on its own. Take this test today, write the number down. If it's above 12, bring it to your next appointment and specifically ask your physician to address it. Most will not have raised it themselves. Now you will. Here is the piece I promised you at the beginning that most people never hear. There is a specific time window, a physiological pattern, when fall risk in adults over 60 spikes dramatically. I call it the silent tilt window. It occurs in the first 30 to 90 minutes after waking from sleep, and again in the early to mid afternoon for adults who nap or take blood pressure medication. Here's the mechanism. During sleep, your body suppresses the production of a hormone called aldosterone, which regulates blood pressure and fluid volume. Overnight, blood pools slightly in the lower extremities. The autonomic nervous system, the one that maintains your blood pressure when you stand, becomes less responsive. In a younger body, this resets almost instantly upon waking. In a body over 60, the reset can lag, sometimes significantly. The clinical term for what happens when you stand up too quickly in this window is orthostatic hypotension, a sudden drop in blood pressure that sends too little blood to the brain for several seconds. Lightheadedness, a brief visual blur, that slightly off balance moment as you walk to the bathroom at 2 a.m. That is not sleepiness. That is your blood pressure failing to catch up with your posture. Research published in the Journal of the American Geriatric Society found that adults over 65 with orthostatic hypotension had a 50% higher risk of injurious falls compared to those without it. Not stumbles, injurious falls, the kind that end up in emergency rooms. I had a patient, I'll call him Robert, 76, a retired engineer from North Carolina. He came in after a fall in his bathroom at 6:30 in the morning. He'd slipped, he said, except there was nothing to slip on. Dry floor, rubber mat, good lighting. His blood pressure readings in my office were perfectly normal. In fact, they were textbook. But when we measured his blood pressure lying down and then immediately upon standing, the drop was 22 millimeters of mercury. He had significant orthostatic hypotension, almost certainly made worse by his evening blood pressure medication, which was still fully active at 6:30 a.m. Nobody had measured his blood pressure lying versus standing. Nobody had connected his medication timing to his fall window. If you take your blood pressure only sitting, in the middle of the day, you may be measuring your most benign window. The correction here is specific. Measure your blood pressure lying down, then immediately after standing. Do this in the morning before any medication. If the difference is 20 or more millimeters of mercury on the systolic reading, the top number, that is orthostatic hypotension, and it needs to be part of your clinical conversation. Now, all of this analysis depends on one thing, that your balance and gait assessments are actually accurate. And that is a much bigger problem than most people realize. Mistake 1: Testing yourself right after eating a large meal. Blood is diverted to the digestive system after eating, reducing what's available to the brain and balance centers. This can add 2 to 3 seconds to a tug test and artificially worsen standing balance. Not because your balance is worse, but because your physiology is temporarily redirected. Mistake 2. Wearing soft cushioned footwear during self testing. Thick soled shoes and memory foam slippers reduce proprioceptive feedback. They muffle the signals your feet are sending. A study in gait and posture found that adults over 65 showed measurably reduced stability in highly cushioned footwear compared to thin soled shoes. Always test your balance barefoot or in thin soled footwear. The results will be different and more honest. Mistake 3. Testing when fatigued. Balance performance in adults over 60 drops measurably after 2 p.m. in adults who are not well rested. Testing your tug or your one leg stand at the end of a tiring day can add 3 to 5 seconds to your result. Not because anything has changed, but because fatigue directly impairs the vestibular and proprioceptive systems. Test in the morning after the silent tilt window has passed, typically 90 minutes after waking. Mistake 4. Not resting before the tug. Rushing the test or performing it immediately after walking in from outside introduces cardiovascular arousal that throws off your baseline. Sit quietly for 5 minutes before testing. This matters. Mistake 5. Testing only once. A single balance reading is noise, a trend is signal. If you test yourself once and get a result, you have one data point. If you test yourself once a week for 4 weeks and the number is rising, you have actionable information. Any single result, good or bad, can be an outlier. Stack all 5 of these mistakes together and you can add 8 to 12 seconds to a tug result that don't reflect your real balance function at all. Your real baseline comes from 3 morning tests, barefoot, well rested, at least 90 minutes after waking, repeated weekly. That is what should guide your clinical conversations, not one rushed attempt in a doctor's office. One of the most common questions I receive is, when does a stumble stop being something to monitor and start being something that requires immediate action? Here's the two-path framework. Path A stumble or near fall with no other symptoms. You caught yourself, you're fine. Your heart rate is elevated because it was alarming. What you do now? Sit down, breathe, give yourself 5 minutes. Think about the context. Were you rushing? Low light? Unfamiliar surface? Medication taken within the last 2 hours? Temporary causes like anxiety, a missed meal, or a sudden change in activity level can produce a single stumble in an otherwise stable person. This is something to note, log, and mention at your next appointment. It is not on its own an emergency. Path B. A stumble, fall, or sudden loss of balance accompanied by any of these symptoms. Call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. Those symptoms are sudden severe headache with no prior history of headache, any loss of consciousness, even briefly, vision changes in one or both eyes, slurred speech or difficulty finding words, numbness or weakness in any limb, particularly on one side, or chest pain or palpitations accompanying the loss of balance. These are not dramatic descriptions. They are specific clinical signs that the brain is not receiving adequate blood flow, or that something is actively happening inside the skull. A stumble with any of these is not a fall risk conversation, it's a stroke protocol. Know the difference between a spike and a crisis. That distinction alone may save you years of unnecessary anxiety, or save your life when you need to move fast. Let me bring this together because I want you to leave this video with something concrete. Not just something you heard, something you can use today. Balance depends on three systems, not one: vestibular, proprioceptive, and visual. After 60, all three decline. Stumbling usually reflects a failure in one or more of these, not clumsiness, not aging, just happening. Gate speed below 1.0 meters per second, roughly one room length in 10 seconds, signals elevated fall risk in adults 60 to 74. Below 0.8 meters per second for those 75 and older. Below zero point 0.6 at any age over 60 requires prompt clinical attention. Run the tug test. Sit, stand, walk 10 feet, return, sit. Under 10 seconds, normal. 10 to 12 seconds, watch zone. 12 to 20 seconds, seek evaluation. Over 20 seconds, act now. Repeat monthly and track the trend. Change over time matters more than any single score. The silent tilt window runs from 30 to 90 minutes after waking and again post nap or post afternoon medication. Do not rush through this window. Sit on the edge of the bed for 60 seconds before standing. Move slowly until the window passes. Measure orthostatic blood pressure. Lying down, then immediately standing. A drop of 20 or more millimeters of mercury systolic is orthostatic hypotension and is a significant treatable fall risk factor. It will not show up in a standard seated office reading. A stumble with headache, vision change, facial droop, one sided weakness, slurred speech, or chest pain is a medical emergency. Call for help immediately. Do you know your tug score? Have you ever measured your blood pressure lying down versus standing? I'd genuinely love to know. Tell me in the comments. And if you've experienced increased stumbling or a fall in the past year, share that too. Your experience may become the subject of a future video, and it helps me understand exactly what this community needs most. I read every comment on this channel and I respond to as many as I can. If this video gave you something useful, I have three quick asks. Subscribe if you haven't, for the reasons I mentioned earlier, and because there's much more coming on balance, medication interactions, and what I call the hidden fall risk factors no one mentions. Click like, not for me, but because the algorithm uses that signal to show this content to other adults over 60 who are searching for exactly this information right now. And share this with someone who needs it, a parent, a sibling, a friend who's been chalking up a few stumbles to nothing. Here's the reframe I want to leave you with. A stumble is not a verdict on your future, it's a data point. It's your body being specific with you, naming a system, flagging a window, identifying a gap that can almost always be addressed. Every stumble you understand is a fall you have the chance to prevent. I am Dr. Kalb. Take care of yourself because the people who love you are counting on you to be. Let's leave.